Okay, so, oh yeah, get the bass up. Thank you so much for that very generous and warm introduction. And I just would like to start the hour by thanking ThyCa. I actually about 20 hours ago was in Spain giving talks, and I was planning to fly back to San Francisco, but ThyCa is really a highlight of my year every year. I feel like this is the most important audience to speak to, much more important than colleagues in endocrinology and endocrine surgery, because in the end, we're all here to serve our patients. And so Gary did not have to twist my arm very hard to make sure I stopped in Houston to spend time with you. So it is an incredible honor and an incredible privilege to be here. And I say that not only to the people in the room, but also anyone joining us virtually. I wish you were able to be here with us. There is still so much to be said for the contact, the human contact, particularly among patients and between clinicians and patients, that I think all of us gain so much energy from. But I'm also very thankful that members of ThyCa are able to join us virtually, because I feel like we have democratized access to expertise. And I don't think we can always say that in America and in the world. So I'm very thankful for everyone joining from around the world. So for those of you in the audience, you can see I put all the different histologic subtypes of thyroid cancer on my name badge because, you know, all of them are so important to our mission to take the very best care of patients with thyroid cancer. But in this talk, I am going to focus my energies on differentiated thyroid cancers. So that is papillary, follicular, and oncocytic thyroid cancer. And for those of you who maybe haven't been to ThyCa for a couple of years, you know, oncocytic is a new term that we have introduced into our lexicon just in the last year or two. It, of course, replaces the term Hürthle cell carcinoma. So Hürthle cell carcinoma has now become oncocytic carcinoma. And my remarks today really pertain to all of those histologic subtypes. So what I was going to do is, you can do anything but not everything in an hour. So I was going to do sort of a quick overview of some of the most relevant and maybe most controversial guidelines that we anticipate coming out in 2025 from the American Thyroid Association. I put next to the title on my title slide a seismograph, and a lot of people are like, you must have a seismograph because you're from San Francisco and we have a million tremblers and earthquakes. But I actually have a seismograph because I actually think a lot of the Sentinel guidelines will be changing in 2025. I think in a very good way, in an evidence-driven way. And so practice change is on the horizon. And I'm excited to share some preview with you. These are my disclosures. They pertain primarily to medullary thyroid cancer, which I'm not going to talk about with you today. Really, the relevant disclosure is that I am one of the two co-chairs of the task force or committee that has been writing these guidelines over the last several years. So when I'm not thinking about thyroid cancer, I love to read. It's my favorite activity. How many of you have read Adam Grant before? Yeah, Adam Grant. So he's really spectacular. He's an organizational psychologist. He's not a physician. He works at the Wharton School of Business in Philadelphia, and he's hot on social media, and he's a really great author, and he's written many books. I recommend them all to you. But this one, I think, is really kind of cool and kind of special. Think Again, it was published during the pandemic, and it was really rooted in the pandemic. And it really focuses on this idea of change and change management. One of the famous quotes from the book, once we hear the story and accept it as true, we rarely bother to question it. And that is certainly true in medicine and surgery and science, right? Where we get into practice patterns, and the way we do things is the way our grandparents did things, and it's comfortable and it's easy and it seems to work okay. But is that really the best way to serve our patients, to practice medicine, practice surgery, and to live life? Well, it gets at this idea of change, and I don't know how you feel, but I would say I hate change. Change is really, really hard. And a lot of people are like, why is change so hard? And I think change is really because it's really energy intense, right? If you're a baby, change isn't hard because you don't have to unlearn and relearn, right? Everything is new, de novo, and it's much easier. But for those of us in the room who are a little older, it's hard because to change means you have to unlearn what you already thought you knew and then relearn something different. And it brings into tension two things. On the one hand, survival anxiety, where we all know we need to change to survive, right? That's evolution. But at the same time, there's a lot of anxiety about this process of unlearning and relearning. And I think that's why all of you are here, right? Is to really unlearn some things and relearn what we are doing and why in American Thyroidology. Okay. All right. So what do we need to sort of unlearn and relearn? So this is the epidemiology of thyroid cancer in the United States. I used to say that there was a pandemic of thyroid cancer, and then 2020 came and that word got stolen by COVID. So now I just say there's an epidemic of thyroid cancer in the United States. We experienced this epidemic, an increase in incidence of thyroid cancer by 300% over 3 decades. It really is affected every demographic subgroup, young, old, women, men, racial and ethnic minorities. And there's been a lot of debate about why that happened. But the important thing is we did some things that controlled the epidemic, because some of the epidemic was artifactual, and it came from almost certainly some degree of overdiagnosis and overtreatment of subclinical thyroid cancers. And you could say, well, what have we done differently that has resulted in a flattening of this curve and epidemic in the United States? One thing is we issued guidelines from the American Thyroid Association, from the NCCN, which has led to practice change. We have a higher threshold for biopsying and interrogating nodules. We're going to talk about changes in surgical approach. We've also changed the lexicon of thyroid cancer. And some things that were called cancers before, the encapsulated follicular variant of papillary thyroid cancer, now referred to as the NIFT-P, which we now know is not a malignancy. It may be a precancerous lesion, a neoplastic lesion, but not a cancer. And then the U.S. Preventative Services Task Force issued guidelines in the United States to not screen asymptomatic adult patients for thyroid cancer. And so you see, just over the last several years, since the publication of the last iteration of the ATA guidelines, we've seen a flattening of that curve. So the nice things about guidelines in the United States is that they are publicly available. And I have to say, a clinic doesn't go by in San Francisco where I don't have at least one patient and patient's family that brings these guidelines to the clinic and holds me accountable and says, Dr. Sosa, what are your recommendations and how do those benchmarked guidelines? So these are available to patients. We're going to talk later about how I think we can maybe make them better for patients, more accessible, more understandable, and embracing a really important theme called shared decision-making, where the patient becomes a more active participant in the process around choosing the best pathway to care. Well, you could say enough about guidelines, Dr. Sosa. It's like, who cares about guidelines? You write them, they're long, they're hard to understand. Does anyone read them and does anyone abide by them? So this is a really important and interesting study that was published just a couple of years ago. And there's two panels. The panel to your left, which looks at low-risk thyroid cancers. So low-risk thyroid cancers are defined as cancers between 1 and 4 centimeters in size, confined to the thyroid, that have not metastasized to lymph nodes outside of the thyroid. To the right, that right panel, is higher risk thyroid cancers, so those cancers less than 4 centimeters. And just at a very high level, you can see the two panels are very, very different, right? You don't see a lot of important pattern changes. You see a lot of noise, but no big pattern changes for high-risk thyroid cancer. But look at the dynamic to the left, right? A lot of dynamics. So you see that gold line. That shows a rapid rise in the use of total thyroidectomy without radioactive iodine in the United States. And that's because in the last guidelines published in 2016, there were fewer indications for the use of radioactive iodine. In fact, it is not recommended for low-risk tumors. So people definitely listen to those guidelines. You also see the black line, a decline in something. That is a decline in the use of total thyroidectomy with radioactive iodine. And then as an endocrine surgeon, I think this is very interesting. You see a rapid rise beginning in the use of thyroid lobectomy. So instead of taking the whole thyroid out for low-risk tumors, only taking out part of the thyroid. And all of these practice changes reflect changes in guidelines. So I would conclude the guidelines do lead to practice change, and the greatest dynamic has been for low-risk tumors. Well, this is another sort of, I think, an important study that we did looking at survival in the United States for patients with all forms of thyroid cancer. And again, there's two panels and they're very different. Looking first at the panel on the left here, this is disease-specific survival for all thyroid cancers of every stage. And what you see when you magnify it is that survival has improved from the blue line several decades ago to the red line, much better survival. And I think it is the result of many things, but overall changes and improvements in thyroid cancer care in the United States. But here's the frightening figure in the panel to your right. This is survival for patients with distant metastatic disease, and there has been no improvement observed yet in survival for those patients. That's in spite of all of the small molecule therapies, the TKIs that we have developed. We are not yet seeing change. And this, to me, is a call to arms, that we really need to focus on improving survival for our patients with the highest risk cancers. Well, if we step back, whether you're a patient or a clinician, I think you need to do this. This is how I think about evolution in thyroid cancer care. The way we do many things today reflects what we were doing 30 or 40 years ago. In other words, this concept of what is old is new again. So let's now turn, that's sort of some background to set the stage and frame for you. So let's focus on guidelines. So the next iteration of guidelines are not yet published. So everything I'm showing you today is literally a preview that virtually no one has seen. We've only shown a very few audiences this. So everything will be in draft form. It is right now getting ready to go out to members of the American Thyroid Association and then to peer reviewers at the journal Thyroid. We expect the guidelines to be published in 2025, but I want to share them with you so you can be thinking about them and also, importantly, provide feedback. Feedback is so important. It's important from physician and clinician colleagues, but it's also important for patients. So one big change from 2016 guidelines, those guidelines were for both thyroid nodules and thyroid cancer and differentiated thyroid cancer. This time we are splitting nodules apart from thyroid cancer. So I'm going to be focusing just on thyroid cancer. The nodules guidelines will be published after ours, and separately, the leaders of that effort are Lisa Orloff at Stanford University and Susan Mandel at Penn. So whenever you think about guidelines, I think it's important before people look at the evidence and look at the references and criticize the recommendations and the discussion, it's important to look at who wrote the guidelines. And the reason that is that all of us in life have implicit bias, right? We have biases based on our truths and our life experiences, and sadly, we bring it to our day-to-day professional lives. So these are the authors of the next iteration of the ATA guidelines. I want to highlight for you this man, Gary Bloom. So for the first time, and this is long overdue, a patient was included in the writing of the guidelines. But the other things I would highlight is the really transdisciplinary nature of the guidelines. We have endocrinologists, we have surgeons, we have pathologists. For the first time, we have nuclear medicine doctors, the doctors who give the radioactive iodine. For the first time, we have brought a geneticist in. Why? Because we're understanding more and more the mutational underpinnings of thyroid cancer. And again, for the first time, the inclusion of a medical oncologist. Why? Because there are all these new small molecules and TKIs being used to treat advanced thyroid cancer. And also for the first time, we had a methodologist, Roger Chu, join us to help us look at the science. So I'm a surgeon, so I am the surgical chair. My medical colleague is Matt Ringel, who is at The Ohio State University. And these are the 4 surgeons who have helped us to write the next iteration of the guidelines. I'm not sure any of them are here at ThyCa, but they're all super terrific. So if I were looking in my crystal ball at a very high level, these are some of the areas of biggest change coming. One is going to be the continued rise of active surveillance, and we're going to talk about that. A second is more support for intraoperative nerve stimulation and monitoring to improve the safety of thyroid cancer surgery. Third, continued motion towards a less is more approach to thyroid cancer surgery. Introduction of the term NIFT-Ps, that is the former encapsulated follicular variant of papillary thyroid cancer. NIFT-Ps are neoplastic, not cancerous. Use of the term oncocytic carcinoma as opposed to Hürthle cell carcinoma. De-escalation of post-operative, post-management survivorship, and then enhanced granularity of the medical and other options for locally advanced and metastatic thyroid cancer. So in this talk, I'm going to quickly go through a new framework for how we think about thyroid cancer care, some new lexicons so you can start to use these terms with your thyroid cancer team, the grading system that we used. I'm going to talk a lot about active surveillance and the extent of surgery. I'm going to talk to you about how to use thyroglobulin levels in a new way. And finally, can we ever say goodbye to a thyroid cancer patient who has low-risk disease and who appears to be no evidence of disease? So you may start to see this figure. It's called the data framework. It's how we're going to think about the patient journey through thyroid cancer care. And it starts obviously with a D, diagnosis of thyroid cancer. After we make the diagnosis, we assess patients for risks and benefits of different management strategies. We then decide to treat them, and treatment may be surgery or it may be active surveillance. And then a reassessment, the second A, of the impact of treatment on the patient. And then, of course, it's like a life cycle, right? Patients keep moving through the system as they age. So, some new definitions for you. So first of all, active surveillance and disease monitoring. I want to make sure that we're all clear about how to use those terms. They're not the same. Active surveillance is basically when we have a patient with a very low or low risk differentiated thyroid cancer, and we decide, because the tumor is 1 centimeter or smaller, not to operate up front, but rather to follow that patient very carefully to make sure that their disease does not progress. That is not the same as disease monitoring. Disease monitoring is what we do after you have had surgery with or without radioactive iodine. A lot of physicians are kind of, including myself, have been kind of sloppy using those two terms interchangeably. They're not. We're also going to change how we think about persistent versus recurrent disease. In the old days, we thought these were two different things. We thought persistent disease was when, say, you had surgery for thyroid cancer, and then they did an ultrasound after your surgery, and thyroid cancer was still seen, left behind, okay? That was persistent disease. It was left over or still there. Then we talked about something different called recurrent disease, which means, say you had surgery, they then did an ultrasound, no evidence of any cancer left behind, and then 5 years later, a new metastatic lymph node was seen. So that's called recurrent disease. So those were two separate things. We are now going to propose that recurrent disease was in fact persistent disease from the start, but it just could not be identified or detected with a blood test like a thyroglobulin level or with ultrasound. So they are on the spectrum. Recurrent is actually persistent disease. We're then going to think a little more, with a little more granularity, about predicting risk of recurrence. So many of you who've had the diagnosis of differentiated thyroid cancer for some time, you go to see your clinician, and they talk about you as being low, intermediate, or high risk for the development of recurrent thyroid cancer. The problem for now several years has been the intermediate category was a basket that was very large, and people were very different. Some were low intermediate and some were high intermediate, but we treated them all the same in our recommendations. In the new guidelines, we are going to divide the intermediate risk patients up into low, intermediate, and intermediate high. We're not talking about likelihood of dying. We're talking about likelihood of developing the cancer coming back, okay? So more refined guidelines. And then we're going to introduce a word that, in my experience at least, we've never used in thyroid cancer, but we use in every other form of cancer, and that is use of the term remission, okay? Who's heard the term remission before? Yeah, we talk about it in breast cancer and lung cancer and colon cancer and pancreas cancer, but for whatever reason, I don't know, it's never been used for thyroid cancer, and so we're actually going to introduce the term remission, and you will start to hear your doctors talk about the concept of remission. This is the system we're using around grading the evidence supporting the recommendations we make for patients. And it's just something to be aware of when you look at the guidelines. Okay, so this is all pretty high level. It may be hard to get your head around. I find it. These concepts are big, they're complicated. It's much easier to understand guidelines when you actually apply them to a case. Usually it's your case or a loved one's case, but I've made up a case, and we're going to go through the case, and you're going to see how we're changing the recommendations we're making to colleagues. So we're going to start with a 33-year-old woman who has a neck mass. She has no other symptoms, and she is clinically euthyroid, meaning her thyroid function tests are normal. And basically, she has a nodule on the right and a nodule on the left. The left nodule is the bigger nodule, 2.5 centimeters, about the size of a nickel, and it appears to be benign. In the right side, she has a much smaller nodule, just 1 centimeter, but with ultrasound characteristics, pathognomonic for papillary thyroid cancer. So she has a biopsy done only of the right side, the small one, but the more worrisome one, and it comes back showing papillary thyroid cancer, okay? Very common scenario. I'm sure there are people in this room or on this Zoom who've had something similar to this. So the question is, what should we do for this patient? So here's the interesting thing. Going back to 2015, 2016, the guidelines said pretty much you should do a lobectomy for most patients who have a tumor 1 centimeter in size, confined to the thyroid without any spread outside the thyroid. You could do a total thyroidectomy if there were nodules on the other side, if there was a family history of thyroid cancer, or if the patient had had radiation. And then a word that very few people actually noticed in the guidelines, but that was a big deal for us when we wrote those guidelines, and that is, we said if surgery is chosen, which opened the door just a little crack in 2016 to permit the concept of active surveillance. That is, not operating up front, but rather watching a patient with a small thyroid cancer. But that was the only mention, 1 word, 2 letters, if surgery is chosen. This is a draft recommendation in 2024 for the next iteration of the guidelines, and you will now see active surveillance becoming more prominent. Active surveillance may be offered as an appropriate management option for some patients with tumors less than or equal to 1 centimeter. Okay, it's not saying you have to do this, but it's saying it may be appropriate to do that. So that's very different. In the past, we said you pretty much should have surgery, at least a lobectomy. So I know a lot of people hear this and they're like, oh my goodness, that sounds like revolutionary change. Are there data to support this? So there actually are. It's very interesting. This was a study published in 2022. We started with 719 different publications. We finished with just 18. Why? Because the quality of the data is overall not very good in thyroid cancer. But it's very interesting. In these 15 studies, we looked at the experiences of more than 75,000 patients. And what we found is that if you have a tumor less than or equal to 1 centimeter, the likelihood of your dying, developing distant metastasis, or experiencing a recurrence was the same, whether you did or didn't have surgery. Both groups experienced very, very, very low rates of bad things happening. In fact, nobody died. And if a patient initially had active surveillance and switched over to surgery, it wasn't because they progressed, meaning their cancer grew or spread to lymph nodes. It was because they became anxious. And that's really important, something I want everyone in this room to think about. And this is this idea that if 2 treatment options are essentially equivalent based on evidence, we need to find better ways to practice shared decision-making, where you as patients or loved ones of patients more actively participate in decision-making with your clinicians, and the clinician is not in a tell culture telling you what he or she thinks should be done. This large study is not the only study that has showed active surveillance and thyroid lobectomy being equivalent for these very low and low risk tumors. This was another study that came to the same conclusion. So with a 33-year-old woman, maybe like some of you in the clinic, she was given both options. She could have surgery or she could have her tumor watched, her 1 centimeter tumor watched. So she said, I don't want surgery. I would rather be watched, and I will come for ultrasounds. Tell me what I need to do. I don't want an injury to my nerve, to my parathyroid glands. I don't want a scar. So we now provide for your clinicians guidelines on how to do it. Basically, number 1, ultrasound is the key study, and it should be done at 3 to 6 month intervals. And number 2, thyroglobulin levels are not useful. They should not be used as a tool for active surveillance. And this is a big departure. We used to put thyroglobulin on a pedestal, that it means a lot, but now we know in the preoperative setting that is simply not true. We also say what to do if things change. So if you're in active surveillance, but your tumor spreads to lymph nodes, if it grows by 3 millimeters, you develop distant metastases, if it spreads outside your thyroid, or frankly, if you as a patient are anxious, you're uncomfortable with this strategy and the ambiguity that potentially comes with it, we say, absolutely, you should change that strategy. So in the case of our patient, and this is the idea of shared decision-making, there was a small amount of growth, 3 millimeters to 1.3 centimeters, and now the patient felt anxious. Now, in the old days, some clinicians would say that's not important, but it absolutely is important how patients feel, their values, and their preferences. And she said it's time to take this out. So the question then becomes, what surgery should we do? So now we're back here, back to treatment. We assessed her, she had growth, and now we're going down the surgery route. Well, the last iteration of guidelines said that the initial surgical procedure could be either a lobectomy or a total thyroidectomy for a 1.3 centimeter tumor. They were essentially equivalent. They had different risks and different benefits. Both were okay. That's going to change in 2025. We are now going to give the edge to thyroid lobectomy. So you can see if your tumor is less than or equal to 2 centimeters, so not all the way up to 4, but less than or equal to 2 centimeters, without spread outside the thyroid, without spread to lymph nodes, the initial surgical procedure should be a thyroid lobectomy. Well, you could say, why is that, Dr. Sosa? Why are you saying it's better than total thyroidectomy? The reason is that the long-term outcomes are equivalent, meaning survival is the same either way, but there are many fewer complications following thyroid lobectomy compared to total thyroidectomy, and that includes in the hands of high-volume thyroid surgeons.
Maybe we could take a question from the virtual audience. Dr. Sosa, somebody asked an oncocytic question.
Yeah.
Where does aggressive vascular Hürthle cell fit in? If it's in the blood, it's traveling. So is it acting like a metastases?
Yeah, so we're going to come to oncocytic carcinoma a little later. And remember, we don't use Hürthle cell anymore. So just a reminder, this would be about oncocytic carcinoma. In the old guidelines, we lumped papillary, follicular, and oncocytic together. In these guidelines, I'm going to show you we've teased them out separately, and there will be separate guidelines for Hürthle cell carcinoma. I then want to show you this guideline, which again has changed. Okay, has changed, and that is if your tumor is a little bigger, between 2 and 4 centimeters, We're still saying thyroid lobectomy is probably preferred, but it's less definitive, less conclusive. And again, it is because survival is the same, but the short-term outcomes, quality of life, is superior if you have the smaller operation. And then we also say, we're not forcing anyone to do anything. And it is this increased respect to patient autonomy and the ability to express values and preferences. And we say, you don't have to do anything. If you, for whatever reason, prefer to undergo total thyroidectomy and understand the relative risks and benefits, you absolutely should formulate that strategy together with your clinician through the process called shared decision-making. So this patient, remember, has two nodules, the one on the right and also a benign nodule on the left. And even though that other nodule looked completely benign, she was anxious. And she said, I don't want it to be followed anymore. I want my whole thyroid out. So she elected that last pathway, and a total thyroidectomy was performed. And the guidelines say that's absolutely a fine choice. This is what she had. She had a 1.6 centimeter papillary thyroid cancer. 1 of 5 lymph nodes had a microscopic focus of metastatic disease in it. There was no extranodal extension. So this is a very, 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 very common scenario in papillary thyroid cancer. So what do we think about this patient? What stage is she? So she's stage 1, right? She's less than 55, even though she has a metastatic lymph node, right? When you're under 55, you can only be stage 1 or 2. You can't be stage 3 or 4. She has excellent anticipated long-term survival. And we would say she is at low risk for developing a recurrence. Well, some people at this point, and I'm anticipating this, say, well, shouldn't we check the mutational status of her tumor? Should we do ThyroSeq? Should we do Vericyte to understand if she has a BRAF mutation or a TERT mutation? And the answer is no. We should not do that for the overwhelming majority of patients with differentiated thyroid cancer. It really only has a role in locally advanced and metastatic disease where we're going to look for a druggable target. So back to this patient. Now she moves into the assessment phase, the second A. And the next question, I think, is should we give her radioactive iodine? What do you guys think? She has a micrometastasis, 1.6 centimeter tumor, had a total thyroidectomy and a central neck. Who says give radioactive iodine? God, you guys are smarter than half the endocrinologists and surgeons in America. This is a sophisticated group. You're absolutely correct. The recommendation in 2016 and the recommendation today would be do not give radioactive iodine to the patient. So then the question becomes, okay, how are we going to monitor her? Not surveil. Remember, the term now becomes monitoring. That's fine. So this is the way we think about it. And these are terms I really want everyone in this room, if you have a loved one or you have differentiated thyroid cancer, this is the way your endocrinologist or surgeon should speak to you about your response to therapy. So they may say you have an excellent response. They may say you have an incomplete biochemical response. They may say you have an incomplete structural response, or you have an indeterminate response, okay? So those are the 4 options. Now, here's the thing. Those 4 options with the attendant parameters were set in an era where everyone, say for low-risk differentiated thyroid cancer, had a total thyroidectomy and radioactive iodine. But I've already showed you data that that is not what we're recommending anymore. Very, very few patients overall now get total thyroidectomy and radioactive iodine. Most are getting total thyroidectomy without radioactive iodine or thyroid lobectomy. And the question becomes, what is the meaning of a thyroglobulin level in these new clinical scenarios? So in our patient at 6 weeks, let's look, she had a TSH of 0.35 and a TG that was elevated at 3.2. But we don't freak out, right? We allow declination of the thyroglobulin level, and 6 months after surgery, her TG is down to 0.8 with a TSH of 1.2. We don't suppress low-risk patients, right? We very rarely suppress patients nowadays. And her neck ultrasound looks clean, looks good. So the question is, we think she's had an excellent response, but due to that thyroglobulin level, we're a little confused, okay? We're a little confused. But remember, the definitions were based on total thyroidectomy with radioactive iodine, but she, like most patients today, had surgery without radioactive iodine. So the question is, does thyroglobulin have meaning if you don't do a total thyroidectomy with radioactive iodine? So it's a great question. Nobody knew the answer literally until 2 years ago. This is the study we did to try to answer this question for the first time. We started with 827 studies. We finished with just 37. To cut to the chase, this is the problem with the literature in a lot of thyroid cancer, which is why I and others who are speaking to you have spent our careers on the science of thyroid cancer. The quality of the science has historically been very poor. And it's not because those of us doing the science are bad scientists. It's because the disease is relatively rare and fortunately has extended survival. So to make meaningful conclusions, it takes decades to assemble enough evidence. And so we're left with what is overall very poor evidence. But if you look at that evidence, what you find is that thyroglobulin levels lose meaning in patients who only have a lobectomy or who have total thyroidectomy without radioactive iodine. They're really only meaningful if you've had the total thyroidectomy with radioactive iodine, which is a smaller and smaller group of patients over time. So overall, the evidence is sadly often thin. But we couldn't identify a threshold for thyroglobulin after lobectomy. Following total thyroidectomy, the problem of the data were all over the place. Sometimes the TG was drawn before the radioactive iodine. Sometimes it was drawn after the radioactive iodine. And in the end, we couldn't find any reliable thresholds. But when push comes to shove, this is, and this is the first time people are seeing this number, this is probably the best milestone or bar to use when a number is less than or equal to a range of 1 to 2.5 nanograms per milliliter. So these are draft recommendations. And just at a high level, you know, we can look at the details. But if you've had the total thyroidectomy with the radioactive iodine, there's a lot of precision around thyroglobulin antibody levels. If you've only had the surgery without radioactive iodine, there are fewer numbers because we only have this range. And then if you only have thyroid lobectomy, you see no thyroglobulin numbers. This is a big, big change of frame from 2016 is how to use thyroglobulin levels. So something to know, depending on what surgery you had, whether you did or didn't have radioactive iodine, how to communicate with your clinicians after 2025. So in this patient, she was followed for 5 years. Her TGs stayed in that range, low. Her ultrasounds remained clean, okay? So she has a continued excellent response. The question is, are we going to continue doing ultrasound and thyroglobulin levels for the rest of her life? She's only 33. She's going to live maybe 60 or 70 years. So this has been a quandary for many, many patients, many, many physicians and clinicians. And so these are draft guidelines, but what you will see is a potential end to monitoring for some low-risk patients. And so you see across categories, patients being followed for 5 to 8 years. But if they have continued excellent responses during that time, and depending on what their thyroglobulin levels are doing and what surgery and radioactive iodine treatment they received initially, there may actually be an end to monitoring. So that is the de-escalation of monitoring. So you could say, well, how could that possibly be a good thing for patients? Think about the costs these patients are having for 60 or 70 years, every 6 months having an ultrasound and a blood test. The anxiety that comes with the testing, the waiting for the results, the waiting for somebody to call you back and interpret those findings for you. So we feel that there may be, for a small subgroup of patients, I am not talking about intermediate risk patients, I'm not talking about high risk patients, and I'm not talking about low risk patients who do not have durability of excellent response. But this group of patients, the low risk DTCs, this is probably about 80 to 85% of all patients with differentiated thyroid cancer. Now, we had a great question about oncocytic carcinoma. And after the guidelines in the past, people have been so frustrated because, let's face it, papillary thyroid cancer is the gorilla, right? It represents 85, 90%, in some series, more than 90% of all new differentiated thyroid cancers in the United States. But what if you're one of those fewer number of patients with follicular thyroid carcinoma or Hürthle cell, now called oncocytic carcinoma? Where do you fall out in the guidelines? And there was no recommendation or set of recommendations for you. So a big change is this figure. It's a magical figure. It goes separately for papillary, follicular, and oncocytic. So it has different guidelines for each of the histologic subtypes. And each set of guidelines extend from patients with low risk to high risk disease. So what it allows you to do as a patient and your clinicians is to get this figure and see where you are. Which histologic subtype, what risk category, why you're in that risk category, and then to task your clinician to make sure that your treatment recommendations are aligned with those. You see what I mean? So it's really much, much more granular, I think sorely needed. Now, I've shown these very preliminary draft recommendations to a very small group of clinicians around the world. You're the first patient group to see them. And a lot of people, when I'm done talking, they raise their hands and they say, okay, so you're basically, Dr. Sosa, saying less is more. And that's not what I'm saying. And I want to make sure no one leaves the room today thinking that's the recommendation. I think this is something that people said as recent as a couple of years ago, certainly 5 or 10 years ago, where we were doing less surgery, less radioactive iodine. I just love this slide. It's a very colorful slide. But I actually would go with something different. And y'all know Frank Lloyd Wright. Y'all know Frank Lloyd Wright. He's not a thyroid surgeon or a thyroidologist, really super famous American architect, but he got it right. And what he said is less is more only when more is too much. So what is he really saying? And it's what we are saying in these guidelines. And I think this is the first time in the guidelines we've sort of ponied up and said this, and that is we need to be striving for personalized treatment recommendations. So these are recommendations that are tailored to each individual patient as best we can. Why? Because each of you has a different truth, has a different life experience, has a different tumor, a different behavior of that tumor. And understanding, A, how that tumor is likely to behave in you is important. And secondly, when the evidence is unclear, whether treatment A or treatment B is better, to be able to equip you as patients with the information you need to deploy your values, your preferences, your attitudes to choose the better treatment strategy, not for him, not for her, but for you. And that's why these guidelines are longer. That's why that figure has 3 different histologic subtypes. So I hope that everyone will find them more useful. Why? Because in my opinion, the patient is in the center. You are the epicenter of everything. Everything we should do should be focused on you in all aspects, your biology, your mutations, and your preferences. So what do I think is coming? There's change coming, for sure. I think change is scary. And I also want you to know, who likes bologna sandwiches? It's like my guilty pleasure. I'm probably going to have a bologna sandwich later. So, you know, there's change, and then there's just change for change's sake, right? This is change just for change, right? But no one wants to eat their bologna sandwich like that, right? That tastes terrible, right? You want a bologna sandwich that's put together. So I think the change we should embrace is change that is informed by evidence that resonates with patient and not just for the sake of change. So this is what endocrine surgery looks like at the University of California, San Francisco, very diverse, dynamic, super famous group of thyroid surgeons. Some of you, I think, even are patients of some of these surgeons. This is what we would look like if we didn't change, right? And I don't know, Rembrandt, Vermeer, they were amazing painters, but in 2024, we don't want a Vermeer on our wall. We want something really dynamic. So on behalf of UCSF Surgery, many thanks for the privilege of speaking. And this is a question I have for you. And I would, if anyone has any thoughts now or immediately after the talk or in the chat, I would love to get your feedback. What are good ways or the best way to involve patients in writing guidelines? So we, with these guidelines, included one patient, Gary Bloom, who's amazing, but he's one patient, right? And I think it's better than not having any patients. It's what most guidelines at best do, but I think it is woefully inadequate, and I think we must do better. I have some ideas. I'm not going to share them because I don't want to color this group with ideas, but I think we need to find better ways to involve patients in guidelines writing, guidelines feedback, and to do that in a dynamic way. And I would love to hear any thoughts y'all have. With that, I'm done.
Any questions?
Could I get clarification on one slide where you talked about for low risk of recurrence patients with excellent response to therapy, they could maybe not be monitored after 5 to 8 years. So I initially had an intermediate risk of recurrence with some high risk features, but then I had excellent response to therapy for 5 years. And my understanding from the 2015 guidelines is that that then subsequently puts me in a low risk category. So would that chart not apply to me in that case?
Yeah,
The
thank
initially
you.
intermediate risk?
So just to bring everyone up to speed, so this is a very sophisticated question. So we think about risk, it's actually kind of cool. We think about risk in thyroid cancer in 2 ways. It's not static. So we initially give you a risk classification or category right after your surgery with or without radioactive iodine. But then we superimpose on that a dynamic risk stratification evaluation, which can change as we follow you over time. And that means, you know, you may be like this patient, and thank you for your question, intermediate risk moving into an excellent, a low risk response over time. So he was sort of converted. You may start as a low risk patient and you move dynamically into a higher risk category. And what I would say is that's sort of nuanced, and we actually have a figure in the recommendations specifically overlaying the first risk evaluation with the dynamic risk. If I were, and I always think this is dangerous to try to get away from the N of 1 and talk in generalities, I would say that the evidence suggests the dynamic risk classification is the more accurate and relevant one, okay? But we have a figure, stay tuned. We address that.
We do have a question online. Is the type of cancer mutation, for example, BRAF, considered in determining treatment regardless of the size of the nodule?
Yeah, so when the BRAF mutation, BRAF comes in many different flavors and variety. As many of you know, it's tied to papillary thyroid cancer in the arena of differentiated thyroid cancer. And it is usually, though not always, the BRAF V600E mutation, which is a druggable mutation. When this mutation, which was really the first mutation identified tied to differentiated thyroid cancer, there was a very famous JAMA paper that basically suggested it was all important. It drove survival, it drove recurrence, and so it should drive all decision-making. And if you had a BRAF V600E mutation, you should basically do everything possible. We have now come to understand that the landscape of mutations associated with thyroid neoplasia and thyroid cancer is much more complicated, not only driven by single point mutations, but by combinations of mutations. And so we have come to put BRAF V600E, I think, in its place, where it is one thing we consider, but by no means should be the sole driver of treatment. And I will give you a scenario. If I have a patient with a 1.5 centimeter BRAF V600E mutation, PTC, nothing else, no lymph nodes, I'd be very comfortable doing a lobectomy for that patient. That patient does not need a total thyroidectomy, does not need radioactive iodine, but definitely needs careful monitoring. I nearly slipped, monitoring going forward. There are other mutations, TERT, combination of TERT-BRAF, TERT-BRAF-ALK, we can start throwing different mutations together. It's like a salad. But when you start additively looking at these mutations, then you start worrying more and more, where we might think very differently about extent of surgery or extent of treatment. So BRAF V600 has gone from being, I will honestly say at one point, it was like all important to one of many factors that we must carefully consider and weigh.
Hi, I was wondering if there was anything in the guidelines official or changing in the official guidelines about assessing a patient post-operatively with a scan while considering RAI, and if that has any weight on proceeding with that treatment.
Yeah, so you will see radioactive iodine is a very complicated topic, and I sort of just had to pick and choose some broad things to talk about today. There's a whole section on radioactive iodine. At a high level, what would I say? I would say that the rise of thyrogen continues. So for those of you who have had this diagnosis or have had radioactive iodine, you'll know that in the old days, not even that long ago, everyone was withdrawn in preparation for I-131. Then recombinant human TSH was developed. And then we were confused or unsure about whether there were specific indications of one or the other. I would say at a high level, recombinant human TSH, I think, is becoming the preferred approach for the overwhelming majority of patients. We also talk about scanning. We talk about dosing. It's very complicated. I would say overall, there have been some small changes in our recommendations without getting into specific cases. I wouldn't say it is by any means the most dynamic area of the guidelines, which is why I chose not to focus on it. But I will say recombinant human TSH is really the way to go for the overwhelming majority of people.
Okay, the question is, will post-surgical physical therapy become standard of care and stated in the new guidelines?
Yeah, thank you for that question. So it's probably, it's probably occupational therapy and rehabilitation occupational therapy and physical therapy, a little different, kind of nuanced. Physical therapy is more around walking and climbing stairs and activities of daily living. All of these are relevant, but probably occupational therapy and rehabilitation and physiatry, even more so, focusing more on the upper extremities, the neck, mobility and kinetic. We do talk about this, the importance of it in short and long term. We do not make, I think I'm correct in saying this, we do not make a specific recommendation. And I would say this is, the guidelines are evolving. One of the things to know in guidelines is that access to clinicians who use guidelines, sadly, in 2024, implies privilege. Not every patient with thyroid cancer has access to a medical and surgical team that is transdisciplinary and includes specialists. I wish they did, like physiatry, physical and rehabilitation medicine. We have privilege in San Francisco and our patients have that. I would say probably the overwhelming majority of patients in the United States with thyroid cancer do not have that access. So it's something we discuss that we need to work towards, but we can't require it because then a lot of people would be out of compliance, and that has medical legal probably implications with regard to insurers, payers, Medicare, Medicaid. So no clear recommendation, an enriched discussion of the topic. I'd put emphasis on occupational therapy, physiatry, and I would recommend everyone in this group, in this session, if you need surgery, ask about access and referral for these things. They actually definitely, in my opinion, in our patients do better.
Thank you. I have a question. Is there anything, oh, here,
Oh, sorry.
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 Anything in the guidelines regarding talking to the patients about risks or genetic risks for their children or
Yeah.
siblings, since there's so much genetic talk now?
Thank you so much for that question. So there are a number of recommendations. They're totally new. Our genetics counselor really helped us to write these. So we talk about appropriate referral, what settings to refer to a genetics counselor. We talk about specific mutational changes. We talk about how the guidelines around extensive surgery should reflect some of this. Like if you have familial non-medullary thyroid cancer, you absolutely should not have active surveillance. You should not have a lobectomy. You should have a total thyroidectomy. Why? Because you are more likely to have multifocal disease and more aggressive disease. So that is enriched, and there are specific recommendations about it.
Hi, I'm curious how the recommendation changes for people who discover they have lymph node metastasis after surgery. If that's, they remove like 20 lymph nodes, 5 end up being positive, but they did have a lobectomy. Does that change the recommendation, or would they need a second surgery?
Yeah, so couple of takeaways here. The first takeaway is that you only find things when you look for them. And sadly, in the United States, I think too many patients undergo first operation without what we call neck mapping, meaning anytime a patient has a thyroid nodule that is indeterminate or high risk, all of the lymph nodes in the neck should be interrogated. And if positive lymph nodes are found, that's not enough. You can't just take those lymph nodes out. You have to do what we call a compartmental dissection, meaning removing all of the lymph nodes the human eye can see in that compartment. Now, even when you do that, and many patients unfortunately don't have that done, those are the recommendations. At the time of surgery, stuff is left behind, either not seen or it's small and it grows back. Then in the old days, we thought it was binary. We thought you had a lymph node metastasis or you didn't have a lymph node metastasis, and all lymph node metastases were created equally, but they're not. We've now come to understand the answer to your question is nuance. It depends on the size of the lymph nodes. So for instance, if you have lymph nodes 3 centimeters or larger, that's going to put you into a high-risk category. If you have extranodal extension, that's going to put you into a high-risk category. If you have a micrometastasis, so our breast cancer colleagues for many years understood the difference between micro and macro metastases. We now know that micrometastases, meaning like that patient, 1 millimeter, 2 millimeters in size, those are not the same as a macrometastasis, a 1 centimeter deposit. So whether you need completion, thyroidectomy or not, to some degree depends on looking at the constellation of characteristics of the lymph node metastasis. But I will be honest with you. If you had a thyroid lobectomy and a thorough ipsilateral, meaning same size, central lymph node dissection, and you only have micrometastasis identified, for the last 30 years in Japan, you're done. And those patients survive as long as those patients in the United States who had total thyroidectomy, meaning a completion thyroid and a contralateral central lymph node dissection. So the data are kind of like unclear whether you need the completion. And that's where shared decision-making comes in. We could do the completion if 2 parathyroids were removed at the time of the first operation and we remove a third in doing that completion, the patient may be rendered hypopara without clear survival benefit, right? So that would be, why did I go ahead and do that? At the same time, you may be someone who worries, or I may be someone who worries, or I'm concerned about compliance with follow-up, where zeroing out that thyroglobulin level, right, makes me feel better, makes the patient feel better. And they say, you know what, I understand the risk, but let's go for it. I will feel better. And I would say that scenario of patients together with their clinician making a decision is not uncommon.
So my question is in a completely different category, oncocytic. So with oncocytic, when you have Bethesda level 3 or 4 based on cytopathology, does that drive what type of surgery should be done? Let's say is in the 2 to 3 centimeter size. And is the category 3 or 4 implies how many oncocytic cells are found, or sort of how many changes there are around them? Basically, what I'm trying to ask is level 3 or 4 dictates different surgery or need for surgery.
Okay, so just so I'm clear, so you're not talking about thyroid cancer, you're talking about thyroid nodule that's indeterminate. And are you talking about TIRADS or are you talking about Bethesda? I think you're talking about a Bethesda category 3 or 4. So just so everyone understands, I just want to level the playing field. So what this questioner is asking is, you have an indeterminate thyroid nodule. That's about 30% of all thyroid nodules in the United States, where it is benign and malignant, but we can't tell based on the cells, okay? So the risk could be as low as 10%. It could be as high as 30 to 50%, okay? In the old days, we took all those nodules out. And in much of the world, that's still what people are doing. The problem with doing that is the overwhelming majority in the end will not be cancer, right? They will not be cancer in a Bethesda 3 and 4 category. So what we now try to do in the United States, I would say it's becoming standard of care, is molecular testing. So you get a Bethesda 3 or 4 category back, and it reflexively is sent for one of the commercially available tests. And I have no skin in that game. You've probably heard of some of them, Veracyte, ThyroSeq, whatever. The purpose there is to try to refine the shade of gray into a whiter shade of gray or a darker shade of gray. I would say, how do I make the decision? So I like mutational molecular testing. I don't have a favorite company, but I do like that. Why? Even though I'm a surgeon, I don't want to operate if I don't have to operate on a patient. I really believe bad things can happen in the operating room. And if we don't need to operate, let's avoid it. So I would do that. I would then take the results of my molecular testing. I would take the ThyRAD's description of the nodule, including size. 2 to 3 centimeters in and of itself means nothing, but is it taller than wide? Is it hypoechoic or is it isoechoic? Does it have smooth borders? Is it irregular? What's the status of the lymph nodes? Often when you assemble all those things together with the demographics of the patient, is it a man? I worry more than a woman. Is it a young patient? Is it an old patient? And I put them all into the decision-making. And in the end, it's a recommendation to the patient, right? And I don't think there's a right or wrong answer at a high level, except there is a right or wrong patient for each, a right and wrong decision for each specific patient. Patients will say, I want it out. A different patient, same scenario, will say, I absolutely do not want surgery.
Is having those oncocytic cells in those samples having
So oncocytic cells in and of themselves are not meaningful until they are put in the larger landscape, okay? Like if you have chronic lymphocytic thyroiditis, Hashimoto's thyroiditis, you will have those cells, right? The question is, what else do you have? If you have colloid, it's probably not worrisome. Let's say there's no colloid, that's worrisome, right? Is there other atypia? Do you see Samoma bodies with those oncocytic cells? So I would just caution you about hanging on 1 or 2 things. That's what we did 10 years ago. It's what some people still do. But I think the better approach is to put it in the big formula. Okay? And it's very complicated.